In part 2 of my interview with Dr. Jordan Vaughn, we talk about the latest research on abnormal clotting in long COVID, whether viral persistence may be driving the problem, and if so, what do we do about it? We also talk a little about long COVID-like symptoms after vaccination. Hope you find it helpful. So in terms of research, what is the latest research that you're aware of happening around this, microclotting and the whole of this associated topic, and what would you desperately like to see research next to sort of fill in the next piece of the puzzle?
I'm trying to fight for even now in my state because I'm trying to get a grant or just actually some of the ARPA money that we have to do a randomized controlled trial on what because I will tell you, the first comment I get from any clinician is, well, where's the randomized controlled trial? And it's like, okay, and again, I agree. I'm biased. Because this is what I know. To me, it works. It's what I see in the clinic, and there's going to be some confirmation bias there for sure. But we need a true randomized controlled trial, and probably that's where we need to go. I know that in England, Ray Duncan and some other folks are trying to get one off the ground. And I know that Jaco and Risha are doing similar things, but I'm hoping to do one here once I get the funding. I would say I have enough resources to do a lot of things, but to run a randomized controlled trial out of my back pocket, I don't have that yet. But it's at some point I almost want to just do it anyway. But that's what we need to get. And so the other thing is, I think the next 10 years of medicine is really going to be exploring the small vessels, because I think the small vessels are the kind of the last bastion of, again, kind of that metaphor I used previously was, it's like you being in your shower, nothing's coming out of your shower head, and you call a plumber, and the plumber stays out in your yard and tells you your 8-inch water main's open. It's like, that's where medicine is. But what if we could come in the house? What if we had good diagnostics to find out that the small pipes or the small vessels are compromised, or that they're, getting sludged up? And I think that's why, this research or even this work in this fibrin aggregate is important, not just for long COVID. It's for, neurodegenerative diseases, chronic microvascular diseases of the heart, all kinds of things. Because when you think about how the body breaks down at the end of life, a lot of the small changes in the brain that we just ignore on the MRI because we can't do anything about them. What if we could do something? And that's kind of my question going forward. So,
the wider medical establishment still hasn't really bought into the idea of abnormal clotting being part of long COVID. What do you think it's going to take for you to be able to go to your GP and your GP to be able to go, oh yeah, I know what may be at risk of happening in your body at the moment, and this is how we treat it. What needs to happen for the medical establishment to believe and take notice, do you think?
So, I think that Risha and Doug's and Jaco's paper, if you read it, the original stuff that they said, basically the S1 subunit causes fibrin deposition that's resistant to fibrinolysis, and it's been reproduced. I think more people have to reproduce it, and then actually, guess what? People have to read it. The problem is most clinicians right now, and I fell subject to this in med school, is things like UpToDate and other kind of what we would call resources that basically collate all our research together and tell you what's really up to date. That's going through a filter, okay? And that filter is going to be biased in many ways. So a lot of people have to get back to how to really go and look at the true research that's in PubMed or the National Clinical Libraries of Medicine. And most doctors aren't trained that way at all. Instead, they've kind of found this side way of listening, especially on very complex topics, to CDC or, other institutes, and just listening to their headline stuff. A lot of times you got to get down in the mud and get dirty with the data and figure out what other people are finding. And I think that's where, just what Risha and Doug were doing. It's the fact that crazy enough, my wife thinks I'm probably pretty crazy, because for the whole last 3 years, I'd wake up and read whatever came over the preprint for, the first 2 to 3 hours of the day. And that's how it was evident to me that coagulation was a huge part of this. Does that make sense?
So, absolutely. So apart from triple therapy and anticoagulation and antiplatelets and the rest of it, what else do you find helps your long hauler patient group? What else do you often throw into the mix that helps manage certain parts of their symptomology?
A lot of times immune overactivation is an interesting thing. And actually, so there are immune modulating things like low dose naltrexone, steroids at some point, sometimes are useful. I will say the further they get away from their kind of acute event or acute exposure to spike protein, again, I'm biased because of this I kind of focus more on the damage done or trying to clean up the mess than, the active participants of the mess or the mess creators. But the other thing that I, weird enough use a lot is in viral persistence is trying to find ways to sequester spike. And, and the spike itself, if it's still up, kind of have given that metaphor before. It's kind of like my dad coming over and playing with my kids at my house. My dad's the virus, my kids are my immune system, and my house is my body. It's like, sometimes you got to get dad to go home and somebody's got to put the kids to bed. So, there's lots of different, ways. And if dad's still up or dad's up and you're over here cleaning up the house, or dad's still there and you're cleaning up the house, it's just kind of a waste of time. So there are a couple of things that I use. And again, I don't have a great way other than some mouse data to show you, but things like checking and making sure that they have a high nucleocapsid antibody, because the nucleocapsid antibody is indicative from of viral clearance. And so if somebody comes to me and they've had COVID and they've been vaccinated as well, and their spike protein's high, but their nucleocapsid never converted, I'm much more worried about viral persistence then, because to me, that means they had an abnormal antibody response to the actual original virus. They didn't produce all the antibodies necessary. And so in those kind of people, we try things. I mean, monoclonal antibodies are an interesting thing to consider, but sometimes have used that a little later than recommended, and it seems to work pretty well. There's other things that are antiviral. I think they're doing some trials on things like Paxlovid, those kind of things to see if there's that. Most of the people I've talked to have tried Paxlovid. When they tried it, they felt better, but then the second that it discontinues, a lot of their symptoms return. So there's something there. I don't know what it is, but this is just kind of, feeling it out from response from my patients. But the other thing is just finding ways to help get them back, their immune systems back to appropriate. So a lot of times getting out in sunlight, not necessarily going and running, but, instead of being in their room all day miserable, at least open up the windows and get, and then diet, sleep. And again, all the long COVID people will probably tell you everything like that's messed up right now, but at least try to get some normalcy to it, because again, I know when we feel awful, we don't really do what we normally should be doing, but there are some, starting at some simple things. But again, the other thing is I tell people, it's a weird phenomenon. A lot of these people are very, extreme athletes, and extreme meaning, they're people that want to run 5 miles a day, 10 miles a day, and now they can't. And then the second they feel good, they'll go try to do it. And I usually say, if this isn't no pain, no gain, this is if pain, or if heart race, if short of breath, it's stop. And so until you get, better from what I would call, again, what biased on it, but what Doug would call chronic ischemic reperfusion injury from the lack of oxygen to the tissues, going and pushing yourself it hurts, and it's not productive.
Well, I completely agree. I was a marathon runner. I was very fit. I was on for a 2-hour 50 marathon when I caught COVID in the final stages of my training. So I was the fittest I'd ever been, the fastest I'd ever been. I kept trying to run for the next couple of months afterwards. And then I realized that and that's kind of, I think, what kicked on the long COVID, was that trying to pick up the exercise again, even though I was capping heart rate, but too high, right? I was capping it at 125, not the 95 that it should have been. So I haven't run in 3 years since then. So yeah, it's a slow old road.
Yeah. And there's hope. The other thing that I would say is to everybody is that there are really smart people, much smarter than me, that are working tirelessly. Unfortunately, a lot of them, to get in the game, had to be injured themselves from COVID or whatever it is. But when they get into the game, they are committed to figuring it out. And I think that's what a lot of the community needs to know, is that there are really brilliant people. And as much as they may feel left down from their local community physicians, and it's really hard to keep up with this space, because there's just so much stuff coming out all the time. But there are people like Doug Kell, like Risha, like Jaco, like Ray Duncan, like I could name multiple. It's, we're committed to figuring it out. So, and the funny thing is we will figure it out.
One final question for you. So there's sort of a subgroup of patients who developed long COVID-like symptoms after vaccination rather than infection. Do they present to you any differently than the patients with sort of COVID-originated long COVID? And do they respond any differently to treatment?
A little bit more kind of neuropathy and vascular issues seem to be more prominent with the actual, I think, and this probably is because of the difference. I mean, obviously the vaccine itself is making you make the S1 subunit, the spike protein, and we know that it makes you make this abnormal stuff. So that's almost like a given. There's less, to me at least, kind of the autoimmune picture as well, but it's more this neuropathy, more vascular, and it seems to be weird enough not as widespread. Like they have weird, it's like in, you know, both of their feet and not everywhere, you know. It's and I don't have, this is very anecdotal, but it's different. It's not this as widespread, I would say, but it's weird enough where it actually affects them is much, it seems to be more intense, if that makes sense. So it's you know, vision abnormalities, feet tingling, engorgement of vessels in weird places. And so it definitely, it's different. It's the same phenomenon, but it's just different, I think, in how it affects in terms of intensity and how widespread it is. And that's, again, the problem is there's not that many of those left, because by now, I've got probably maybe 10 patients that have never had COVID and only got vaccines, and the vaccine really kind of knocked them out. But now everybody seems to have had both. And so it's almost, it's pretty obvious that, you know, the pathophysiology of the vaccine as well as the disease itself are similar in terms of their consequences to the coagulation system. And so it's, you know, again, it's kind of what I would say, it's COVID plus vaccine, vaccine plus COVID, or vaccine plus COVID plus vaccine plus COVID. You know, like it's almost like I want to come up with this nomenclature called like C0, V0, you know, like whatever, like COVID zero, V. And so like instead, because to keep up with it sometimes, just like you would with pregnancy, like to keep up with this, like, you know, pregnancy plus delivery versus, you know, like same thing.
Well, Jordan, thank you so much for your time this morning. Hugely appreciated. And I'd like to speak to you in the future as and when you've had the paper published, and then maybe we can talk about that too.
Awesome. Great to be here, guys. And thank you for what you're doing.